So hello everyone, my name is Enriqueta Felip. I'm medical oncologist working at Vall d'Hebron University Hospital in Barcelona, Spain, and it's a real honor for me to participate in this program. I'm going to review the most updated information about the management of patients with metastatic EGFR mutation-positive non-small cell lung cancer. I'm going to start with a trial, with a study with analysis presented during the World Conference in San Diego from FLAURA2. As you know, FLAURA2 is a trial in first line in patients with sensitizing EGFR mutations comparing carboplatin pemetrexed plus osimertinib versus osimertinib alone. These trials show longer progression-free survival with a combination of chemotherapy plus osimertinib when compared to osimertinib with a hazard ratio of 0.62. And in the second overall survival interim analysis, there was a trend towards an improvement in overall survival with a combination of chemo plus osimertinib with a hazard ratio of 0.75 that was not statistically significant at the time of presentation. So during the World Conference, the authors present the impact of baseline tumor burden defined as the number of metastatic anatomical sites on PFS in the patients included. So overall, they presented the PFS for those patients with low than 3 metastatic anatomical sites or 3 or more metastatic anatomical sites. First, I would like to remember that for those patients with CNS metastases at study entry, the median PFS with chemo plus osimertinib was 24.9 months, with osimertinib alone 13.8 months, with a hazard ratio of 0.47. And for those patients without CNS metastases at baseline, the hazard ratio favoring the combination of chemo plus osimertinib, it was 0.75. So here, the data presented during the World Conference for those patients with at least 3 metastatic sites at baseline, chemo plus osimertinib was associated with a median PFS of 25 months. With osimertinib, the median PFS was 16.4 months with a hazard ratio of 0.57. For those patients with less than 3 metastatic sites at baseline, the hazard ratio with chemo plus osimertinib was 27.9 months, with osimertinib monotherapy 30.5 months. So no main differences in the median PFS, although the hazard ratio was 0.75. Perhaps also to mention that for those patients with intrathoracic disease only, the median PFS was 26 months with chemo plus osimertinib, and it was not reached with osimertinib monotherapy with a hazard ratio of 0.97. So here, my take-home messages from this trial. So we know that chemo plus osimertinib is one of the approved treatments in the first line of patients with EGFR mutations. However, the mechanisms for the observed clinical benefit with the combination are not currently clear. It is possible that the combination overcomes intratumor heterogeneity. In this trial, in FLAURA2, the PFS benefit appeared to be most pronounced among patients with brain metastases at baseline. And I would like to remember that brain scans were performed at screening in all the patients and at the time of progression in all the patients. In the study, PFS benefit was observed with osimertinib plus chemotherapy versus osimertinib alone in patients with high tumor volume. And I think it's important that there was no PFS difference in those patients with only intrathoracic disease with a hazard ratio of 0.97. I understand that this is a subset analysis, but these are the results presented. Also, analyzing the FLAURA2 trial, I would like to highlight the study analyzing the potential mechanisms of resistance and also the impact of the baseline p53 co-mutations. So again, in this trial, there was a number of analyses performed by NGS in ctDNA at diagnosis and also at disease progression, and the p53 mutations were analyzed in tumor sample. So the first message is that when the authors analyze the mechanisms of acquired resistance in both treatment arms, osimertinib or chemotherapy plus osimertinib, the mechanisms of acquired resistance were pretty similar. So it was the presence of the C797S mutation in approximately 7 to 10% of the patients. There were also MET amplifications in approximately 10% of the cases, and other molecular alterations such even BRAF V600, KRAS mutation, and also fusions. So the message is that there were no differences between the two treatment arms in the mechanisms of acquired resistance, and also there were no novel resistance mechanisms detected in plasma for those patients with this sample at the resistance time. And also, as mentioned, p53 was also analyzed in the tissue at diagnosis if the patients included in the FLAURA2 trial. Here, 141 samples were analyzed, and when the authors presented the results for those patients with p53 wild type at baseline, the median PFS with chemo plus osimertinib was not reached. With osimertinib monotherapy was also not reached. For those patients with concomitant p53 mutation in the tumor, the median PFS with chemotherapy plus osimertinib was 27.6 months, with osimertinib monotherapy 27 months, with a hazard ratio of 0.67. So again, and this is the FLAURA2 in first-line treatment of patients with EGFR mutations. My take-home messages are the following. In this updated plasma analysis, the acquired resistance mechanisms remain similar between the two treatment arms, osimertinib or osimertinib plus chemotherapy. No new acquired resistance mechanisms were observed, and the p53 co-mutations seem more prognostic than predictive. Now, I would like to discuss a paper published in a Journal of Clinical Oncology by Dr. Pasijane about the CNS efficacy of osimertinib with or without chemotherapy in EGFR-mutated patients in this FLAURA2 study. We have discussed the results of this trial. So we know that in the FLAURA2 trial, progression-free survival was longer with chemo plus osimertinib when compared to osimertinib in the group of patients specifically with CNS metastases. In this group, the median PFS with chemo plus osimertinib was 24 months, 13.8 months with osimertinib alone, with a hazard ratio of 0.47. And in this publication, the authors present the additional data on CNS efficacy with osimertinib, including the CNS progression-free survival. So for in the full analysis set, the CNS progression-free survival was longer in the chemotherapy plus osimertinib arm versus the osimertinib arm, with a hazard ratio of 0.58. At 24 months, there are 74% of the patients in the chemo plus osimertinib arm that were CNS progression-free compared to 54% in the osimertinib arm. And there was also a subgroup of patients with brain metastasis evaluable. This is the CNS evaluable analysis group. And in this group, also the CNS progression-free survival was longer with chemo plus osimertinib when compared to osimertinib with a hazard ratio of 0.40. Also, there was an analysis of the cumulative risk of CNS progression in the CNS full analysis set, and this progression was higher for those patients treated with osimertinib in monotherapy. And also some data on the depth of the response when you can see the waterfall plot, the patients in the combination arm, chemo plus osimertinib, had a greater depth of response compared with those in the monotherapy arm. And overall, the response rate in these patients is around 70%. So more data of the CNS efficacy in patients included in the FLAURA2. And again, as a summary, overall, in all patients, there was a brain scan at baseline, and in 84% of the patients, a brain MRI was observed. In this analysis, I would like to highlight that the scans were assessed by neuroradiologists according to the independent review committee. And again, among the 222 patients with baseline CNS metastases, osimertinib plus chemotherapy had an improvement in the CNS progression-free survival compared with osimertinib, supporting the analysis of these combinations in those patients with CNS metastases at diagnosis. And then there is another publication also this year, a Journal of Clinical Oncology, that is a phase 2 analyzing osimertinib 80 milligrams, that is the usual dose, patients with EGFR mutations with leptomeningeal metastases. I would like to mention that this trial was performed in patients with EGFR mutations treated with first-line or second generation EGFR TKIs and then progression. So a large number of patients with leptomeningeal disease showing a median PFS of 12 months and a median overall survival of approximately 15.6 months. And also, you can see the response here according to the independent review committee and according to the RANO criteria. It was a response rate in 51.5% of the cases, and we have discussed with a median PFS of 11.2 months. So this is the publication in JCO in August, analyzing this dose of osimertinib, 80 milligrams, in patients with leptomeningeal metastases. I think the results and the efficacy was pretty good. However, as recognized by the authors in the discussion, there is an important limitation. That is that in this trial, patients were included after first and second generation EGFR TKIs. And we know that now the standard of care in first line are third generation EGFR TKIs or the combinations. And perhaps another important point is that there are some pharmacokinetic analyses in this trial, and there were all trials showing that perhaps in these patients, double dose of osimertinib, 160 milligrams, may help. However, this study supports the standard osimertinib dose even in patients with leptomeningeal metastases. Let's move on to the other combination that is being analyzed and approved in the first-line setting of patients with EGFR mutations, the Mariposa trial, so the combination of amivantamab plus lazertinib in the Mariposa trial, patients with activating mutations, EGFR, treatment naive, were randomized to receive the combination of amivantamab plus lazertinib, osimertinib, or lazertinib. Lazertinib was analyzed in this study to determine the action of this component. Was a requirement by FDA. So we knew that this trial was positive for progression-free survival. This was presented at ESMO 2023 in Madrid. But this year, during the World Conference, there was an update in data presented. So in this update, we have seen that the intracranial progression-free survival was longer with amivantamab plus lazertinib when compared to osimertinib. It was also a longer intracranial duration of response with a combination of AMI plus laser. The time to treatment discontinuation was also longer with a combination when compared to osimertinib. Also the time to subsequent therapy, longer with amivantamab plus lazertinib, and also the PFS2. So the time from the inclusion until the progression after the first subsequent therapy was longer in the AMI plus laser arm when compared to the osimertinib arm. During the World Conference, there was also an updated overall survival analysis. There was a longer overall survival with AMI plus laser when compared to osimertinib. At that time, this was a numerically longer with a hazard ratio of 0.77, although it was still not statistically significant. However, we have seen in a recent press release by the company that in the final analysis, the overall survival is positive, favoring the combination of amivantamab plus lazertinib, and also they mention that is statistically significant and meaningful positive. So we need to see these results in the future meeting, but according to the press release, the improvement in median overall survival with AMI plus laser is expected to exceed 1 year. So again, my take-home messages from this presentation. And I'm discussing what was presented in San Diego. So after longer follow-up, data continued to favor first-line amivantamab plus lazertinib over osimertinib with a promising overall survival trend in patients with EGFR mutations. We have seen that the overall survival curves separate early and widen over time, favoring the combination. We have discussed also the press release. And I think also there is a scientific rationale to give this combination because we are addressing potential mechanisms of resistance to osimertinib, blocking EGFR and also MET. It's true that the combination, there is a high incidence of adverse events, and the toxicity management of this combination is relevant. And again, the data support the combination as first-line treatment in patients with EGFR mutations. And also during the World Conference and analyzing the same study, there was a presentation about the patient-relevant outcomes. And overall, the summary is that the time to symptomatic progression is longer with like the combination when compared to osimertinib, and the quality of life was maintained in both treatment arms. And we know that the combination has more toxicity, but the quality of life was not affected. So again, this was the presentation about patient-relevant outcomes from Mariposa, and the main points, in my opinion, is that the amivantamab plus lazertinib combination delay symptomatic progression compared to osimertinib, and probably symptomatic progression is a patient-relevant endpoint. It's an important for the patients, and quality of life was maintained in both treatment arms, and overall, the increased adverse events from amivantamab plus lazertinib did not meaningfully impact patients' health-related quality of life. I had the privilege to present during the ASCO meeting and also to publish with all the co-authors at Annals of Oncology the combination, the analysis in the Mariposa trial for those patients with poor outcomes. So overall, in this study, in the Mariposa, all patients had EGFR mutation, but also in the literature, we know that there are a group of patients with poor prognosis. And these are the patients with brain metastases, with liver metastases, with concomitant P53 co-mutation at baseline, and also those patients with detectable ctDNA at baseline. So during the ASCO, we presented the analysis, the comparison between amivantamab plus lazertinib versus osimertinib in these patients with poor prognosis. So for those patients with history of brain metastases, AMI plus laser improved progression-free survival when compared to osimertinib with a hazard ratio of 0.69. It's true that also there is an improvement in PFS for those patients without history of brain metastases with a combination. Also, for those patients with concomitant P53 co-mutation at diagnosis, there was an improvement with a combination when compared to OSI with a hazard ratio of 0.65. For those patients with detectable EGFR mutation at baseline in the plasma sample, also longer PFS with a combination when compared to osimertinib with a hazard ratio of 0.68. And also for those patients without clearance of EGFR mutations at week 9, for this group of patients without clearance, the combination of amivantamab plus lazertinib improved progression-free survival when compared to osimertinib. So the summary is that even in the patients with poor prognosis, that are the patients with brain metastases, liver metastases, detectable EGFR mutation at plasma, concomitant P53 co-mutations, and detectable EGFR mutation at baseline. In all these subgroups, the combination of AMI plus laser improved progression-free survival when compared to osimertinib. And these were the summary of our presentation at ASCO. So we have detected that approximately 50% of patients with EGFR mutations at diagnosis had concomitant P53 co-mutations, and approximately 70% of the patients had detectable EGFR mutations, had shedding, and we are able to detect in liquid biopsy. We have seen that AMI plus laser improved median PFS versus osimertinib in all high-risk subgroups, so overcomes the effect of these negative prognostic factors. However, it is also true that the combinations also benefit those patients without these high-risk prognostic features. I think it was important that at ESMO, Dr. Benjamin Bess presented the mechanisms of acquired resistance to first-line amivantamab plus lazertinib versus osimertinib in this analysis in the Mariposa study. And again, the results show that amivantamab plus lazertinib reduced the incidence of acquired MET amplification and also reduce the incidence of EGFR resistance mutations when compared to osimertinib, so supporting also the mechanism of action of amivantamab. So it seems that perhaps the HER2 amplifications were slightly higher for those patients receiving the combination. And also, this is based on liquid biopsy, but there is no biopsy to determine the small cell lung cancer transformation. But overall, the patients with P53 RB1 loss that are related to a small cell lung cancer transformation were less common for those patients treated with amivantamab plus lazertinib. And also, the authors presented that osimertinib had a higher frequency of complex resistance mutations than amivantamab plus lazertinib. So again, the summary of this presentation, using ctDNA NGS analysis, AMI plus laser reduced the incidence of MET amplifications and also EGFR resistance mutations when compared to osimertinib monotherapy. There was a low rate of P53 and RB1 loss that is associated with small cell lung cancer transformation. And also, I think, is the confirmation of the scientific rationale of the combination that is trying to proactively address the mechanisms of resistance to osimertinib blocking EGFR and MET. A few words about the Mariposa-2 trial. This is in the second-line scenario. It was previously presented at ESMO and also updated by Dr. Popat during the ESMO meeting. Patients previously treated with osimertinib were randomized to receive chemotherapy or chemo plus amivantamab. There is also another arm of chemo plus laser plus amivantamab, and this was updated during the ESMO meeting. And again, in the overall survival, there was a trend towards an improvement in the overall survival for those patients receiving chemo plus amivantamab when compared to chemo alone, with a hazard ratio of 0.73. Although it was not statistically significant, still it was not the case, and the trial is ongoing and will proceed to final overall survival analysis. And also, all the other endpoints analyzed benefited also the combination of chemo plus amivantamab second line when compared to chemotherapy alone. So again, the summary of this presentation from Dr. Popat about the Mariposa-2. At the second interim analysis, there is a promising overall survival trend favoring AMI plus chemo in the post-osimertinib setting. There was also an improvement in time to symptomatic progression, time to treatment discontinuation, time to subsequent therapy, and also PFS2. But this is a scenario in which we will have a lot of Asians. So there would be the possibility perhaps to give targeted combinations in presence of fusions or BRAF V600. We have also antibody drug conjugates and also the possibility probably in the future of chemotherapy plus biospecific antibodies. And finally, I think this is the last presentation by Dr. Leith at ASCO and also published in a Journal of Clinical Oncology in patients treated with lazertinib plus amivantamab. It was the PALOMA-3 compared the subcutaneous amivantamab presentation versus the intravenous amivantamab presentation. The primary endpoint was the PK, and it was a non-inferiority design, and it was demonstrated that the subcutaneous administration, it was not inferior when compared to intravenous from the PK objectives. But it was also important that the response rate was exactly the same with the subcutaneous or amivantamab or intravenous presentation. Progression-free survival and duration of response, there were no differences. And interestingly, there was a trend towards an improvement in overall survival with the subcutaneous administration when compared to intravenous presentation. Importantly, there was a decrease in the adverse events with the subcutaneous administration. The infusion-related reactions were observed only in 13% of the patients in the subcutaneous arm versus 66% in the intravenously arm. And also the VTA, the venous thromboembolic events, were less common for those patients with a subcutaneous formulation. For those patients with prophylaxis in the subcutaneous arm, BTAs were seen in only 7% of the cases. So I would like to mention, and this was discussed by Dr. Jessica Lins at ASCO. I think the summary is that the subcutaneous amivantamab demonstrated a PK non-inferiority. There are a number of advantages in safety. There is a reduced rates of infusion-related reactions and VTEs, and it's not inferior in efficacy. And there is this intriguing signal for improved overall survival that needs further investigation. The hypothesis is that perhaps the impact of subcutaneous administration on lymphatic absorption and immune stimulation may help, but I think there is something that requires other analysis. So I think in the future, the subcutaneous formulation of amivantamab could be an interesting option in the clinical practice. Finally, a few words in immunotherapy. I think with with pembrolizumab and nivolumab, no clear activity of the combination of chemo plus nivo or pembrolizumab after osimertinib resistance. And probably, I think here the future could be the bispecific anti-VEGF and anti-PD-1 antibodies in combination with chemotherapy. So I think these are the summary of the presentations that, in our opinion, change the standard of care for patients with metastatic EGFR mutations. I'm very pleased to participate in this initiative. Thank you.